Guys, this is Dr. Shivek Singla. Welcome to my YouTube channel. So guys, in this video, I'm going to discuss about a very important topic from the Electrolytes abnormality series, that is hyponatremia. So guys, as you know, the normal values of the serum sodium level is 135 to 145 milliequivalent per liter. Hyponatremia is when the sodium level is less than 135 milliequivalent per liter. So there are two types of hyponatremia: pseudo hyponatremia and the true hyponatremia. The pseudo hyponatremia is further divided into two, with normal osmolality and the high osmolality. So when there is a normal or the high osmolality, that is the pseudo hyponatremia. Causes of normal osmolality so hyponatremia with normal osmolality is hyperlipidemia and the hyperproteinemia. And with the high osmolality is when there is a hyperglycemia or the patient is given mannitol. Okay, so this is very important, guys. You have to first classify the hyponatremia in pseudo and the true. So now true hyponatremia is hypoosmolar. So when we have diagnosed that it is a true true hyponatremia, then we go to check the extracellular fluid. So if the ECF, there are three type of classification further. If the ECF is normal, if it is increased, or it is decreased. So first of all, we came on the normal ECF. So it is a hypoosmolar with normal extracellular fluid. The causes will be, you can remember with the DSP mnemonic. So D for drug induced, that is thiazide if it is given. S for SIADH, and the P is stands for psychogenic polydipsia. So extra note is that if it is associated with hyperkalemia, if hyponatremia is associated with hyperkalemia, then the cause of this will be aldosterone deficiency, means hypoaldosteronism. Now, so this was the normal ECF. If the ECF is high, so these patients are like edematous patients. Okay, then we go for the urinary sodium levels. If the urinary sodium levels is less than 20 milliequivalent per liter, then we can remember the causes like CCN. C for congestive heart failure, and another C for cirrhosis and the nephrotic syndrome. When the urine sodium level is more than 20, the causes will be renal failure. Okay. Now, if the ECF is less, if decreased, if there is a contraction, okay, ECF contraction is there, then the patient is like in the hypovolemic state. If the ECF is more, then it is a edematous stage, and if it is less, then it will be a hypovolemia stage. Then we classify further also on the basis of urinary sodium. If the urinary sodium is less than 15, then it will be the extrarenal losses, and if it is more than 20, then it will be the renal losses. What are the causes of the extrarenal loss of the sodium? Like diarrhea, vomiting, and the burns. And the different renal causes of the loss of urinary sodium that will renal losses are excess diuretic use, salt wasting nephropathy, and the cerebral salt wasting syndrome. So now let us guys discuss the different treatment modalities for these type of hyponatremias. So if it is a true hyponatremia with the ECF normal, then we have to treat only with the water restrictions. So only water restriction is the treatment of the normal ECF. If there is a high ECF edematous patient, then the treatment will be salt and water supplementation. You can give 0.9% NS, normal saline 0.9%. And if it is if there is a hypovolemia, then we have to both water and the salt restriction plus loop diuretics you can give. So this is a very important slide, guys. You have to remember this by heart. It is constantly asked in the INSCT and the NEET PG examinations. This is very important, guys. Next, what are the different clinical features based on the serum sodium levels? So if the serum sodium levels is around to 120 milliequivalent per liter, then there will be confusion and the restlessness, and the ECG will shows white KORS pattern. If it is about 115 milliequivalent per liter, then the clinical feature will be like nausea, somnolence, and the ECG will shows white QRS plus ST depression. And if there is a sodium level of 110 milliequivalent per liter, then there will be seizures and the coma, and the ECG pattern will show ventricular tachycardia and the ventricular fibrillations. So these clinical features are also very important, guys, in the hyponatremia causes. So there is a note, very important, guys. When there is severe hyponatremia less than 110 milliequivalent per liter, we have to correct this hyponatremia with the 3% NS. Okay, and the rate of correction with the will be around 0.5 milliequivalent per liter to 1 milliequivalent per liter. So this is 0.5 milliequivalent per liter. Okay, guys. Now, if so, we have to make the rate about this. If the rate of correction is more than this, then there will be central pontine myelinosis, and the clinical feature will be like dysarthria, dysphagia, and the flaccid and the coma. So this is very very important, guys. This hyponatremia is a very very important, guys. In the next lecture, we will discuss how to correct the sodium levels. So thank you. This is Dr. Shivek Singla signing off. Bye bye.